This is going to be a full breakdown on the Advisory Committee for Immunization Practices ACIP's meeting on June 27th, 2024, focusing only on the 3.5 hour section that looked at COVID vaccines. For a little background on current recommendations, both Moderna and Pfizer vaccines are approved for all people 6 months and older, and Novavax is only available in people 12 years and older. After unvaccinated COVID children get the initial primary series, which would be either 2 doses of Moderna or 3 doses of Pfizer, for whatever the current vaccine is at the time, they should then get 1 dose a year. As of September of 2023, immunocompromised people with approval from their healthcare providers can get a COVID vaccine every 2 months. And for people aged 65 and over, they could get the 2023-2024 vaccine formulation for the XBB 1.5 variant 2 times at 6 months apart. For those that haven't gotten it yet, do not wait. The World Health Organization advises getting it now. In terms of timing, if you get it now at the end of June, 2 months from now, you'll be able to receive your updated vaccine for the 2024-2025 formulation with no delays. In addition, if you are underinsured or uninsured, the Bridge Access Program ends in August, presumably at the start of August, meaning that that program will not be available for the upcoming vaccine, so you should take advantage of that before it ends. And for the updated 2024-2025 vaccine formulas, they will either be targeting JN1 or KP2. We know for sure that Novavax will be targeting JN1 and that Pfizer will be targeting KP2. Moderna is up in the air. I assume they will pivot to KP2. However, prior to the FDA's announcement of officially recommending KP2, Moderna had already submitted an application for JN1, so it's uncertain how that will impact their ability to switch. Within this presentation, we got a good overview of what the COVIDNet program is. For those unfamiliar, that's our last hospitalization-based surveillance program for COVID in the US. As outside of this program, around April, hospitals were no longer required to report COVID hospitalizations. And this program is incredibly limited. It only reports on 98 counties in 13 states, where it only represents about 10% of the US population. And it's even more limited by the fact that it's only if people actually test for COVID, that it's being counted within that program at those sites. So when we're looking at the COVID dashboard for things like test positivity and emergency department visit trends and hospitalization rates, that's where that information is coming from. Next, we learned something very interesting with COVID-associated hospitalizations broken down by age groups, where our highest age group is obviously those over 75, but then the next highest age groups are those under 6 months, which is the pink here, which is then closely followed by those 65 and older in the teal, where it's important to note that the only way that these under 6-month-old children are able to get a vaccine is through the mother getting vaccinated during pregnancy. So the mother would then pass the antibodies from the vaccine onto the infant, which truly helps to underpin the importance of maternal vaccination. But what I found to be even more striking was this percent weekly hospitalization by age group, where those 18 and older all approximately have the same hospitalization risk. To be clear, it wouldn't be considered equal risk, but you can see that there's very clear delineations between each, showing that it's certainly not negligible, which underpins the message that anyone that gets COVID can get hospitalized from that COVID infection. Where I'd then like to focus on this slide here in this text box over here, where it reads that 50% of infants, children, and adolescents under 17 years of age with COVID-19 associated hospitalizations have no underlying medical conditions. So to put this another way, half of people under the age of 17 that are being hospitalized with COVID have no comorbidities. They're completely healthy, but they're getting a COVID infection and then getting hospitalized for that COVID infection. Furthermore, of all of these children and adolescents under the age of 17 that were hospitalized with COVID, only 5% of them had received a 2023-2024 COVID vaccine. To put this another way, 95% of those individuals were not up to date on their COVID vaccines. And then I'd also like to emphasize that adults aren't faring much better. 57% of COVID-associated hospitalizations among adults over the age of 18 had not received a COVID vaccine after August of 2022, meaning that they had not received a COVID vaccine for over 2 years now, where this number is likely much higher if you consider just the past year, similar to what we saw in children, which again emphasizes that vaccinating for COVID reduces your risk of hospitalization. Next, moving on to vaccine effectiveness. Again, I always love this slide, because you don't vaccinate individuals, you vaccinate populations. And vaccine effectiveness is therefore a population level estimate. What it does not mean is that the vaccine only works 80% of the time if a vaccine effectiveness is 80%. What it does mean is that at the population level, 80% fewer people will contract the disease when they come in contact with it. Where again, I'd like to emphasize this scary fact that approximately 89% of the population has had at least one COVID infection at this point. The next program you should be familiar with is the Vision Multi-Site Network of Electronic Health Records, which focuses on 369 emergency rooms and urgent cares over 229 hospitals, where the predominance of this is mostly in the West. So again, this is very low coverage of the United States population. But what they found and what we've shown before is that by 120 days, so about 4 months, COVID vaccine effectiveness has essentially tapered off to approximately nothing, which emphasizes the fact that we need COVID vaccines at least 3 times a year, if not 4 times a year, to be able to sustain our active immunity. Where we see the same thing immunocompromised individuals, but on average, it's going to be trending to lower efficacies a lot faster, which is why it's important, especially for immunocompromised people, to be taking advantage of that every 2 months vaccination that they're eligible for. You just have to talk to your provider and they will get you on track for that. And then here's the same thing that we're seeing, the same trends of critical illness in immunocompetent individuals, which is another way to say quote unquote healthy individuals. Or I'd like to take a mini aside. So at this point, we know that the vaccines are supposed to be to reduce our risk of severe disease and death, but this risk increases after 4 months from vaccination. And since this is the case, why are we not getting vaccinated more frequently for everybody in the population, not just immunocompromised and not just the elderly? Because frankly, even just the 2 times a year for the past 2 years for people over 65 is not enough. And this excludes the fact that people 50 and older are also at those higher risk levels as well. So, outside of the ability of immunocompromised individuals to get vaccinated every 2 months, our current vaccination schedule and availability makes no sense whatsoever. The next program to be aware of is the IV network. This is also one that tracks vaccinations, but again, it's a very small program, only looking at 26 hospitals over 20 US states. Next is I know a lot of people are concerned about vaccine side effects. There are 3 programs that I want to make you available of. First is VAERS, which is the Vaccine Adverse Event Reporting System. The next is VSafe that you can enroll in here. And then there's the Vaccine Safety Data Link, which does more real-time analysis, where some of the highlights include that injection site redness and systemic reactions such as muscle pain, headache, fatigue are the most common symptoms, where very few people reported being unable to complete daily activities or to attend work or school. And again, those were transient because they were only within 0 to 7 days. They were completely fine after, and only a fraction of a percent sought out medical care, where this is typically due to anaphylaxis, which would be like an allergic reaction to components within the vaccine. The real-time monitoring program looked for signals of all of these different things, where Novavax didn't have enough data to generate signals, so that was excluded. And signals in the data involved ischemic strokes for both Moderna and Pfizer, and Guillain-Barré syndrome on Pfizer only, where I'd also like to emphasize there were no signals for myocarditis or pericarditis or blood clotting, the thrombocytopenia, where the signal for Guillain-Barré syndrome was only noted in Pfizer for those 65 and over, and the ischemic stroke for Moderna over 65, and for Pfizer 18 to 64, where the prevalence for Guillain-Barré syndrome in Pfizer was only 4.1 people per every million doses, which is incredibly low and is well within the safety factor of other vaccines. Where it was noted that this may or may not be a signal, they will continue monitoring. And for the ischemic stroke signals, available data did not provide clear and consistent evidence of a safety problem because there's a lack of consistent findings across age group or risk intervals. But again, they will continue monitoring this to see if it is a problem or not. I'm going to pause here and go on to a part 2.